Morning to all. I thank Jyoti again and JPEF to have been given me this opportunity to chair this important session, and that to one of the top speakers who have come here all the way from Sweden, Dr. Julia, the future of continuous glucose monitoring, because that is where the whole crux of the matter lies, because monitoring and control. And like the whole day yesterday, we had people telling us how to monitor and how to bring it down, because without monitoring, we cannot have a good control. Dr. Julia is a full professor of diabetology from the wonderful city of Graz in Sweden, Austria, and she's a she's a visiting professor, and she heads the diabetic technology research and has done so much of work on insulins, pumps, and continuous glucose monitoring. Over to you, ma'am.
Thank you so much.
I would like to invite our chairperson to give away the token of appreciation to Julia Mather.
Dear Chairman, thank you for the kind introduction. And it's my great honor to talk about the future of continuous glucose monitoring. I initially tried to change to metabolic monitoring, but then I found that there is not so much literature out that I can share with you. So I stayed with the original title. Here are my disclosures. And if we shortly look back in time, and that's quite impressive that only as of 2015 we managed to get the clearance for non-adjunct use of continuous glucose monitoring. So it's quite a recent story. We had glucose monitors already quite some time, and when I started in clinic 2005, we were testing some of the systems, very early generation systems that could not really be very reliable, that could not be used in the home care. But now we have really got a long way down the route, and I think we are on a very good track. So that is the part where I told you when they cleared the non-adjunctive use of continuous glucose monitoring, and the team around Dr. Kovachev, they said that as soon as the MARD, so the accuracy measure, is below 10%, then that should be enough for accuracy, and that is why they cleared it for managing the diabetes with it. When we now look into what has already evolved from standalone continuous glucose monitoring, we have now smart alarms when we have connected pens. So for example, the connected pen tells you in conjunction with the glucose trace when the last insulin dose was taken, when and how much of insulin was taken, and then only alerts you whenever there is a new relevant glucose excursion. So if we look in the past, we have the above curve, where we had a lot of traces with alarms over the time continuously. And nowadays, with the modern approach that the sensor knows something has happened, the alarm will only come again when glucose rises a second time above the threshold or the insulin action time is over. Another relevant new aspect that we have is the low glucose predict, where people in the future will have the chance to go tonight and to have a better sleep without being worried about needing to wake up for their glucose. And these alarms will help us to get better sleep quality and hopefully better quality of life. And it can tell you at around what time the hypoglycemia can happen in case you do not interfere with your current actions. So that will be also a true game changer in the field. What we also talk about, and that's already data from 2021, that we are looking into options of continuous ketone monitoring. And I think that's quite an important aspect as well. Hopefully, if we can have a joint device, that we do not only have standalone glucose monitoring, but joint devices. And here the first preliminary report told us from the one early meter that the accuracy seems also to be quite promising. And why do we need continuous ketone monitoring? Because we still have high rates of ketoacidosis in people with type 1 diabetes. These are data mainly from the US, Canada, and also Austria and Germany and Sweden. And the interesting thing is, in Austria we have data from a period of 20 years, so quite a long period of time, and still we have 30 ketoacidosis events in 1,000 people in that sense. So if we can prevent ketoacidosis by ketone monitoring, that would be also a good advantage. How could that be? So for example, that monitor in the future could also tell you how much of insulin to take, what to do, how often to monitor, and when medical attention seeking could be necessary. So that's just a draft proposal, very preliminary, and I'm also happy that we are part of one of the studies looking into ketone monitoring, and hopefully we will see some results quite soon. Other topics around continuous glucose monitoring are continuous glucose monitoring in healthy individuals, and that is data of 7,000 people without diabetes that were followed with continuous glucose monitoring and also had data from their medical records in, and they could have a look into what medical condition was associated with what glucose trace. And importantly for all of us is that if we look into normoglycemia, we see that in these people, both in the female and the males, above 90% had their glucose in the range of 70 to 180. So we do have now very robust evidence nowadays what is normal glucose, even if we have not yet managed to come across with our consensus, and we are really strongly working on it and advocating for it to also be able to use CGM as a diagnostic tool for the diagnosis of diabetes. So, and in that regard, a group around Annette Ziegler in Germany, they looked into glucose traces of people with early stages of type 1 diabetes, so stages 1 and stages 2 type 1 diabetes. And what they have seen, that they have, if you look from the left to the right, so here we have time above 140, time above 160, and time above 180, that the controls have lower glucose on all parameters, and stage 1 already shows a distinction in the glucose above 140 milligrams per deciliter, and even more pronounced in the ones with stage 2 type 1 diabetes. They also have higher mean glucose and a higher standard deviation. And what we currently are working on is a joint European project which is called Identify, and I'm part of that group that looks into the use of continuous glucose monitoring for staging early type 1 diabetes. Other parts of that study protocol are the development of antibody measurements, how often shall we do it, when shall we do it, in what persons shall we do it, and we are currently looking into the aspect of how often should we use continuous glucose monitoring, which continuous glucose monitor should we apply, and at what intervals should it be done. And I think we had a very strong lecture yesterday about iCGM from Ken, and I definitely agree that for these kind of critical parts we need to have a very accurate glucose sensor that tells us the truth and not makes us more insecure about the diagnosis of diabetes. Recently we also, oh sorry, that's a wrong reference, I wanted to add the EU project reference down there. Recently we were part in an EU project that looked into a continuous lactate sensor. That's a lactate sensor based on small crystals that are penetrating the skin as a micropatch, and it measures concomitantly glucose and lactate. We managed to perform that experiment on a cycle ergometer and also perform meal challenges. And what we have seen, and that are quite preliminary results so far, that actually the lactate patch worked better than the glucose patch on these types of intradermal crystals that measure the glucose and the lactate. For the next future, I guess we can also expect that we will have more of AI and digital twin technology feeding into continuous glucose monitoring, so where we not only have the data from the glucose sensor, but integrate it with variables, may that be the smartphone that already gives you a guesstimate about the steps you took, but of course more clearly a smart watch that helps you. Electronic health records could be aligned with it. And then once you have the digital twin, we can adjust the medication, the therapy, maybe also the psychological support for the people based on their needs and based on their glucose traces. And I've come across a study that was done here in India, which is called Fit-a-Fly Diabetes, and that's an app that was developed using a continuous glucose monitoring system, used then AI and machine-based learning, also had psychologists and nutritionists in there. And they had a 1-week observation using continuous glucose monitoring, tracking activity, tracking meals, stress, sleep quality, and then they came up with suggestions for the individual patient based on the findings from the continuous glucose monitoring phase. And the results, these were 109 individuals here in India, roughly 50 years of age, BMI 27, some of them were on insulin, the majority was on oral hypoglycemic agents, and they already had 5 years of diabetes. But here are the results, and that's quite impressive. So they went down just by that intervention with an HbA1c of 8.4 to an HbA1c of 7.2, and also their time in range increased from 58% to 65%. So that's, after 3 months intervention, quite an impressive result. Of course, it is a preliminary study and we need to see if that's sustainable for the future, but at least a good glimpse what could happen with AI support. Another research group looked into how we can develop apps and what people would want to have in their apps. So I think we need to also listen to the voice of people living with diabetes, because if the advice comes in a way that people cannot cope with it, it might be more of a stress, more of a burden, rather than a support. And here they had really a good suggestion of how we can onboard people living with diabetes to a new device, how can we adjust over time, what are my current pain points, what are my individual gains. And if we don't speak the patient language, it will be difficult to really get a good outcome in that sense. And lastly, and hopefully not unimportantly, I want to introduce you to the Diabetes Technology Report that has been launched in 3 countries in Europe in the past years, and Austria just joined last year. And we had HCPs, but also people living with diabetes, and that's the cohort of people living with diabetes. So we had 2,500 people being included here. And when we asked them about the relevance of technology, the majority of them said that the most important part for them is the CGM, followed by AID, and followed by diabetes apps. And they would really strongly recommend to stay on the technology that they currently have. When we asked them for future trends, they were not as innovative as looking into AI or similar, but they looked for a fully closed loop, smart insulins, and of course the hope for the cure when it comes to immunotherapy and stem cells. With that, and I'll just go back to my previous slide shortly, I would like to also invite India to join that initiative, and I talked already to Dr. Julia about that idea, and I hope that we can manage maybe already for this year to get the DT report also into India, so that we have, of course, very much larger sample size than 2,500 if you spread the word amongst your patients also, and also your HCPs. That will be a survey that takes roughly 10-15 minutes of your time. We will translate it upfront into English and work with you on local translations, and I think that could be a very good joint initiative for the future. I also would like to invite you, as in my second role as being part of the EASD, to also spread the word about our e-learning platform, which was relaunched. It is fully free for everyone. You just need to register with your email address, and then you can use all the resources. You can also use it for teaching and for your students. We also have modules about diabetes technology there. And of course, the ones who are willing to join us in Vienna for our sessions. We have an e-learning session there at our annual meeting that you can follow. And it is fully CME accredited, the whole platform, so you can download the certificates and get the platforms, the certificates for your modules. And lastly, keep in mind we have the early registration fee coming up for EASD, 16th of July. For all of you who want to come to Vienna, it is now a good time. And whoever needs support for going to visas, just drop me an email. It worked last time quite nicely, that we could help you to get visa for getting into Austria. But not losing track of what we have said, we have CGM that will be hopefully in the future adjuncted by AI and digital twin models. We will hopefully see continuous glucose ketone monitoring entering the market quite soon. Probably we will also have multi-metabolite monitoring, so I heard from several companies that they look into monitoring of other conditions as well simultaneously. And we also have the potential to use CGM to diagnose early stages of both type 1 and type 2 diabetes. Thank you very much for your attention.
Thank you, Dr. Julia, for a nice presentation. I'd like, when you made that comment about diagnosing people early, in the last slide, how do you use a CGM in this view?
So that is the jury currently out. We think that if people have more than 10 to 20% above 140, that can be a hint for having a glucose tolerance issue in that sense. Not meaning that they necessarily need to go on insulin therapy yet, but to have some monitoring capacities, and I think especially in the young children, it's less of a hassle than performing finger prick monitoring, rather to equip them with a sensor. Maybe not continuously if that's not affordable, but at least maybe once every 3 months to have a sensor on them to see if there is an increase in their average glucose, if there is an increase in the time above 140, that would give us some indication that it's time to escalate maybe.
Do you mean to say that we should think of doing a GTT, a glucose tolerance for a common person, or we identify certain people like we do as far as India is concerned only for the during pregnancy we do that. On the other side we don't on a standard basis.
So we also, so I'm not a pediatrician, but as far as I know, our pediatric department does OGTTs also in the children at risk. But of course that's quite a nasty procedure for a kid to have to swallow that solution, to keep it inside, to really swallow the whole amount. So I think it could be easier if we have an alternative for the diagnosis.
I just read about a new non-invasive, there were many of them, but now I think it's just been released, RIS. Mm-hmm. Have you any experience with it?
So that's why I left that part a little bit out, because I'm not yet convinced that it actually works that well. So we've heard the promise that it will be on our Apple Watches soon, on our watches soon. We have not had that yet. I was involved in a study with some European collaborators who claimed they can measure it via ultrasound and infrared light in the vessel. And the hand needs to be put in a very huge device, and it can accurately measure glucose. They always measured 100, so it worked quite nicely for people without diabetes, because if you always have like a flat signal around 100, then you don't have a big deviation. But once we had a glucose swing, the system did not work. So I'm not yet convinced that we are there yet. Maybe in the future, but not so close.
Thank you. Any questions from the...
My doubt is, traditionally we see that diabetic ketoacidosis is common in type 1 diabetes mellitus, and hyperglycemic hyperosmolar state, and SHS is more common with type 2 diabetes patient. Since you commented on continuous ketone monitoring also, with the experience of the internist and a few endocrinologists and a few clinicians I have consulted, they're telling that the cases of HSS are very low. Even my in my personal experience also, I have seen only 2 cases of HHS in my post-graduation time, and as a clinician, almost 1 case. So do you find an increase in incidence of diabetic ketoacidosis in type 2 diabetes also?
Yes, so what we definitely see is with the broader use of SGLT2 inhibitors, especially in people who were already on insulin or on the margin of needing insulin, and then they were seen by some other specialty. For example, they were admitted to surgery department or to some other non-internal medicine specialty, or even internal medicine without focus on diabetes, and they introduced the SGLT2 inhibitor, maybe for heart failure, and took off the insulin or reduced the insulin, and then we had those issues. And interestingly, we had more cases of ketoacidosis in type 2 on insulin rather than on type 1 on insulin and SGLT2. The type 1s who had the ketoacidosis were the ones who did not manage well their diabetes, or who did not do the set changes, who didn't do the injections properly. But I usually only put the ones who know how to handle their diabetes additionally on an SGLT2 inhibitor, and so the numbers of ketoacidosis in type 1 are low, but in type 2 are quite high.
So when do we restart this SGLT2 inhibitors after an episode of diabetic ketoacidosis? Like traditionally, like when I asked many endocrinologists and when I look at the guideline also, there was not a clear-cut guideline when we had to restart. But some of them are telling after 1 week after 1 week after the incidence of diabetic ketoacidosis, that is the initial day, you can resume this SGLT2 inhibitors. Is that so?
Yes, it depends a little bit on the condition and the reason for it. So for example, if it was like infection, I would wait until infection has resolved and then restart. But if it was maybe just because the person didn't inject the insulin, I would wait 2-3 days until everything has settled and we can restart. But if it's a person not managing diabetes well, I would keep the SGLT2 inhibitor away and not restart at all. So could also be the case that I don't restart it.
I hope they can use that continuous ketone monitoring in patients with SGLT2 inhibitors also.
Yeah, exactly. So that will be one of the use cases. So for the type 1s on adjunct therapies, for the type 2s maybe in combination, and on people on AID systems when you see that the infusion set is failing.
Okay, thank you so much.
Thank you. In my country, not yet. Not yet. Just for the clinical study.
You mentioned in your study of 7,000 normal people that the blood sugar ranged between 70 to 180. That would mean it included a lot of people with pre-diabetes. What was the exact percentage of people who you classify as having pre-diabetes in that study?
In the one from SIGA?
In the study of 7,000 patients you mentioned they had a blood sugar between 70 to 180.
Yeah.
That means there would be many patients who were pre-diabetic.
It can be, definitely, yes.
What is the percentage of those people?
They did not say that. They just called them metabolically healthy. I was also a bit surprised that it made it to cell metabolism in that sense, but they did not really depict it in that detail. And I think we are also, and that's what Tade discussed with me yesterday, a bit worried about increasing the numbers of type 2 diabetes, so that's why probably we keep the 70 to 180 more present rather than forcing for a lower range.
Thank you, Dr. Julia, for a wonderful presentation. Thank you for having cleared the doubts also. Thank you very much.
Thank you.
Thank you, dear Chairperson and Speaker.